Great. Lisa, if you don't mind just shooting a quick email or text or whatever you've got for Dr. Saeed or Adnan. We want him to be here for this, and I need Jeff. Jeff, you're there. Great. Okay, we're just going to wait another minute and we'll start. Lisa, can you just confirm that you've reached out to Dr. Saeed?
Yes.
Okay. Still going to wait about 30 seconds, but thank you, CEPAC members. You're all back. Okay. I know we're still waiting for one of the clinical experts, but we will forge ahead. And I want to thank everybody for coming back. So we have an hour to do the voting questions, which obviously bring a chance to deliberate again, to ask questions, both of the clinical experts, the patient expert, to share perspectives with each other, ask questions of the ICER research staff. So let's go ahead and show the first voting question. All right, first, just to be clear, the patient population for these questions are adults with non-alcoholic steatohepatitis with significant fibrosis, and that is specifically stage 2 and stage 3, which have been the target of the clinical trials and of the likely indications considered by the FDA. It does not include patients with F4 or cirrhosis. Next slide. Right. So the first voting question is going to be, is the evidence adequate to demonstrate that the net health benefit of resmetirom is superior to that provided by lifestyle management alone? Jeff, I'm going to turn to you again to do a very brief just summary of the evidence. We have the evidence tables available for the CEPAC members taken from the full report. So if you can, please refer to the specific tables that have the key information, and then we will open it up for discussion.
Great. Thanks, Steve. So for this first voting question, the benefits are summarized in Table 3, the lipid changes with the LDL cholesterol changes in Table 4, and the harms in Table 8. So that's on pages 6 and 7 of the evidence summary. So both doses of resmetirom had significantly greater improvements in the two outcomes we've talked about. An improvement in fibrosis stage of at least 1 stage and no worsening of NASH, and NASH resolution without worsening of fibrosis stage. So both of these meet the patient's outcome that would really meaningfully impact their disease, meaning no progression, and in fact evidence of some regression. For resmetirom, we see a reduction in LDL cholesterol of 12 to 15% versus a slight increase in the placebo group, statistically significant. We're unsure about the clinical benefits. And then harms, no difference in serious adverse events, clearly more diarrhea, no difference in discontinuation rates due to adverse events with the lower dose versus placebo, but a slightly higher incidence of discontinuation due to AEs in the 100 milligram resmetirom group. So again, we thought that the net health benefits, so the benefits minus the harms, I mean, clearly some side effects like diarrhea, potentially serious enough to lead to discontinuation in the high-risk group, but clear benefits on both the intermediate markers that the FDA set up in terms of improvements in both NASH and fibrosis stage, and a reduction in LDL cholesterol, which could translate into benefits. A lot of uncertainty, hence our wide range. A C++ could turn out that these stepwise progressions only happen the first year. It's one thing in the model projects that this continues every year over time. We don't have 5-year biopsy data, so we don't know that these, the benefits that we're seeing are lasting, but certainly we're hopeful, and some of the intermediate markers suggested that other markers suggested that may be prolonged. So we'll see, lots of uncertainty. I guess I'll stop there and let people debate.
Yeah, that's fine. So we had a kind of an early discussion around the surrogate outcomes and the knowledge of the epidemiology of the progression from fibrosis stage to fibrosis stage. Dr. Bradman, is there anything else you wanted to add to that conversation we had this morning that you feel would be helpful to the CEPAC as they consider this vote?
Yeah, I mean, I think really thinking about, again, to reiterate really what is the important thing to look at in fatty liver disease if we're looking at hard endpoints. Right now, this hard endpoint of fibrosis improvement, I think, is really an important endpoint. And I think the data really do show that the drugs are effective in reversing fibrosis. Yes, there's things that are unknown, like length of treatment, things like that. But I think in terms of the effectiveness of the drugs, I think there's little question that there is improvement in fibrosis. And I think in terms of how that translates to clinical outcomes, I think we will need to follow that. But just, how I think about this clinically and how I talk about it with patients is that if you lose weight, for example, and if you have improvement in fibrosis, you've basically kind of bought your liver more time. And I view these drugs as kind of buying the liver more time. And perhaps, the goal is going to be that we buy the liver so much time that we will need to transplant fewer and fewer patients.
Okay, thanks. A quick follow-on question. And then Kimberly, I'd like to ask you too about, from the patient's perspective, if you have any comment about your sense of this evidence around fibrosis changes. Some members of the CEPAC may be wondering why only one randomized trial is a pivotal trial here. Sometimes we see 2. That used to be the norm. Any sense of why there's a single trial for examination here?
Yeah, I mean, I think that it feels like things are moving quickly and slowly at the same time. And I think it's just taken a little bit more time to get some of the data to come out. And it sounds like some of the data did come out after this process started. But, I don't think that detracts from the data that have been shown already. I think it shows we still need to learn more. And, the data that have come out since this are in support of the medications to improve fibrosis. But I don't look at that as a downside from my perspective.
Okay. Kimberly, let me offer you, if you have anything you want to add to this conversation about the evidence at this stage.
I just think that if it does make it go like from 2 to 1 or 1 to 0, that the quality of life will also be affected. And there is so many things, especially things like fatigue, that really it affects everything in your life. So I think that would be a great benefit. And as far as Danielle said about fewer and fewer transplants, that would mean that other people that need the transplants, the livers would be there for them if they had fewer NASH patients on the list.
Okay. Thank you for mentioning that again. All right. Any questions or comments from CEPAC? Kurt?
Yeah, I had one question about the term lifestyle management. So we're talking about usual care, right? We're not talking about aggressive lifestyle management, because that really wasn't done in the trial that we saw, right?
Jeff, do you want to answer that?
Sure. As the comparison, yes, absolutely, you're right. And for the discussion here, yeah, we don't have data in a DPP style, you get a nutritionist who meets with you weekly, you get a personal trainer assigned to you, that level of intervention has really not been studied, at least here.
Okay, thank you.
Jeff, you had your hand up. Did you want to come back quickly?
Well, just one thing you said, there of course is another phase 3 trial of resmetirom, but we didn't emphasize it because it's in all of NAFL patients. It's really not the focus right now, but there is an ongoing trial, and the outcomes are really safety. They're not efficacy. Okay. So there is additional contextual information. It just doesn't add much to our deliberations right now, and it's ongoing.
All right, thank you. I'm really glad you clarified. My apology on that one. Tim.
Thank you. I heard Dr. Tice say that the clinical benefits are uncertain. And I guess I'd like to get a bit of find out whether there's any data on quality of life. I thought it was in the second drug we looked at, but not in the R drug. I would have assumed there would have been some quality of life data in that study, which would get at one of the issues just brought up recently, that improvement in stage leads to improvement in quality of life. Has ICER ever made recommendations strictly based on surrogates? I think our experts have kind of laid out a pretty good point that these are likely good surrogates, but have they done that because it's trying to get me at health benefits where we don't know about clinical benefits? Thanks.
I can handle both of these, Steve. So I've been involved in two, at least I've had two come to mind where we did surrogates. Hep C we already talked about. It was a sustained virologic response at 12 weeks. Did we really believe that was going to translate into long-term benefits for patients with Hep C? Similarly, for the PCSK9 inhibitors, we initially looked at them just with data on LDL changes and no long-term cardiovascular outcomes. We revisited them when there were long-term outcomes, but we have certainly presented data, and the various ICER panels have voted on them with intermediate or surrogate outcomes. And in terms of quality of life, I remember the resmetirom trial has not been published in any meaningful way yet. I'm assuming that they have collected, and I probably saw it at some point on clinicaltrials.gov. I'm sure they collected some measures of quality of life, and we'll report them eventually, but I haven't seen them yet. For context, though, of course, for obeticholic acid, there was no change, no improvements in quality of life, even though people would argue there definitely were improvements in fibrosis stage in a subset of patients.
Okay, thanks. Bijan?
Yeah, I guess my question is, as far as I understand this drug, the follow-up for this particular drug was 1 year. And I think we all sort of, what I have realized is that there's a considerable uncertainty in terms of, whether the 1 year data would be enough to really make any judgment. And the question there in the voting question is not really talking about that follow-up, that it's kind of agnostic of time. Do you have any comment about that, like making a conclusion about the drug, about its effectiveness, and then sort of not really knowing what it would turn out in the future?
I'll just say this is the hard work that you have to do. This is the judgment part that comes into every vote, particularly when we're timing this to first approval. There's always, we always want more data, and it's the hard work of you all who have to vote. I get to just do the easy job of presenting the evidence. You have to actually make a judgment based on what's there.
And often, in some ways, we are the clients of the FDA process in terms of what they stipulate as a duration of effect that they will want to see to make a judgment. Doesn't mean that the companies always do the exact same timeline, but there is a discussion about that. And it's driven in part by any sense of whether it's possible that the effects could wane in some way. If there's biochemical or other kind of information that would suggest that, they might want a longer timeline. But as Jeff said, there's always, and this is the tension that the health system works with, which is that we're always looking at evidence that could be, if you will, stronger if we waited longer, but the trade-off is then that patients wouldn't have access to the treatment until a much later time. David, and then Reem.
Yeah, I probably was going to make almost the same point, which is we're probably going to have at least one of these drugs pretty soon available for prescription, long before we have long-term outcome data that tell us what it does to progression to cirrhosis. And people like me in primary care and people like the hepatologists on here are going to have to decide whether to recommend resmetirom to people with F3 fibrosis, even though no one has yet shown whether it does anything to progression to cirrhosis. And we can't avoid that either judgment is a judgment. It's a decision. If you decide not to use this drug because you don't think the evidence is good enough, that's a real decision if the drug's on the market. And if you decide to use it, you're making a judgment as well. I would encourage everybody to struggle with that.
Reem.
It's interesting. So just really, my comment is on exactly the same wavelength. And I think while 100% agree, Steve and David, with what you said, it is a trade-off between deciding to, move ahead and think about or consider for those who prescribe this medication, prescribing it or not. I wonder if it may be helpful to everybody here to hear about ICER process. So we hope there will be data on actual patient important outcome in the future. And does that play into ICER deciding to update any of these reviews or revisit the judgments? I think it's helpful to state that if that's part of the process.
I suppose I could take that on. The short answer is it depends, because our reports are timed to inform what we've come to learn is a very critical phase right around the time of FDA approval, when coverage policies are developed, initial pricing and kind of contracting is done. What happens after that is a mixture of things. Sometimes we do come back ourselves and take a full look at the entire area again, especially if there are clinical outcomes that were highly in doubt with a certain surrogate measure. On the other hand, we put our economic models into the cloud now for stakeholders so that they can go in and plug in new data as they kind of emerge. And so to a certain extent, we democratize the process and let others do those updates as they see best. And they may have other reasons that they want to change other assumptions in the model or use different cost data, or et cetera, et cetera. So I don't know where we'll be with this in another year or two. It may depend on just whether, if it's blindingly obvious one way or the other, sometimes, again, it doesn't really need an ICER revisit, but we'll see. We'll see. Jeff, sorry, you had your hand up, but you're good now?
Yeah, I guess I was just going to follow up to David's comment. The reason I put my hand down is because it's really about OCA. Of course, OCA is already approved. So in fact, clinicians can prescribe it off-label. So clinicians are already wrestling with this, and we may want to bring that up for the next vote, not for this one. Yeah,
that will get us into territory around whether health plans, insurers will allow it to be prescribed off-label, will cover it, if you will. I bet they watch that pretty carefully. Eric, go ahead.
So, I guess we're not the FDA, right? So I don't have to worry about voting as to whether or not I would approve the drug, and whether or not, it would be clinically appropriate for a particular patient in a particular, setting. But I think and I'm not trying to whip up votes, but our job here, right, is to say, is the evidence sufficient regarding, net health benefit? And I think there are many leaps of faith that we're always asked to do at the Midwest CEPAC, right? This one just happens to be some bigger gaps than I've jumped before, in terms of, from my point of view, like believing a couple different assumptions that have to be stringed together in order to get to, a net health benefit. Given the data that we have, because this is all what it is. Like, we have 1 year worth of data, to work with on a condition that is a prevention strategy for a 10-year outcome. It's just, or whatever. It's probably not that long. So I'm just sharing with the group my thoughts, on it, and that I think our job isn't to approve the drug. Like that's not it. I mean, I feel like my job is to say, what's the evidence regarding our assessment of the net health benefit? And that's not the same. It's not exactly the same question I would say that the FDA is grappling with, particularly on the one product which is already approved.
Okay, I think we're starting to get closer to the time when we could take a vote. I see no other hands raised. I would love for the people watching and for your own benefit to hear from people who are considering voting yes, and from those who might be considering voting no, to hear some of the way that you are putting together these issues, just as Eric described in a way, before we take the vote. So could I please just, again, have, if anybody's willing, I know we've got the slide up again, but why don't you hold off on voting? And if we could take that down again, I'd like to continue the discussion just another couple minutes. But I'd love to have, if anybody's willing to say, I'm going to vote yes because. Anybody willing to do that? Albert, go ahead.
So yeah, I'm going to vote yes for partially because I feel like I've been in this place before in other chronic diseases, and I think the discussion around the kind of the natural history of NASH and what stages were important, and the fact that for this drug all the outcomes are in the same direction, and the second outcome in particular, not the staged outcome, but the outcome where there was actually resolution, I find pretty compelling. So that is, I know it's only a single trial in 1 year, but we do this all the time for a whole series of other chronic diseases. This chronic disease is pretty significant with end-stage outcomes. So that is the reason I'm voting yes.
Okay. Angela and Stuart, if we've got 3 people who are also going to vote yes, I'd ask you if you can, we'll try to be quick because I also want to hear if people are going to vote no, what their rationales are. Angela, go ahead.
I'll be quick. It was in the same vein as Dr. Wong, I think. But definitely, I think what was the final straw for me saying yes was Dr. Brandman's comment of it buys time. So inside of the patient and the caregivers, that was my reasoning.
Okay, thank you. Ingvar, go ahead.
Yeah, I mean, as a frontline clinician for this condition, seeing a lot of these patients and hearing the evidence, if I would have a medication that just stays the fibrosis at, let's say, a 2 when they get enrolled for the rest of their life, I would already be happy. Seeing something that can reduce it gives me the extra cushion to say that even if it fluctuates over time, so I'm not so worried about the 1 year follow-up only, even if it fluctuates over time, that gives me the extra cushion to say if the net benefit, that means all beneficial effect, all downsides, all harms taking into account, that's the reason I'm going to vote yes.
Okay. Anybody going to raise a hand for a no vote? I want to share with us why. Tim and Greg.
I think I'm channeling some of what I believe was voiced earlier, but there are some compelling arguments about the surrogate markers. I just believe that this is too big of a leap of faith in a single trial, and that there's no data on quality of life, and that my job is to really determine if there's clinical and health benefits. And for many of these patients, we wouldn't even know if they had it or had stabilization if we weren't doing all of these laboratory tests in the first place. So from the standpoint of, am I feeling better? Am I living longer? Am I not having bad events? I just think it's too big of a leap of faith, and I'm more probably staying with processes and stakes in the ground in terms of methods on this.
Okay. Greg?
Okay. Thank you, Steve. I think it's premature. We haven't seen any data today that there is a health benefit. And as Tim said, all we can rely on is a leap of faith. And I think that that's a bridge too far. I am personally concerned, maybe more than others, that, I mean, first of all, the phase 3 with resmetirom is still ongoing. That's what I mean by prematurity. But none of the data have been subjected to peer review. None of the data have been submitted for publication at a scholarly journal. None of the data have undergone that kind of important process to evaluate their validity. No one has seen the protocol. No one has seen the SAP. This is all very, very premature, and that is the reason that I will vote no.
Okay, thank you guys and everybody. I think that's helpful. Whether it changes minds or just makes it transparent for others how these votes are going to start to play out. Why don't we go ahead now and take the vote on resmetirom? If we can put the slide back up. Okay, and I hope we have 15 voting members of the CEPAC. So when we get to 15, we can see the results. Okay. Okay, 8 yes and 7 no. Right. I'm glad I asked for people to describe the rationale because it's clear that there were a lot of people who felt both ways about it. Thank you. Let's go to the next question, which is the same framing. It's around obeticholic acid this time. Is the evidence adequate to demonstrate that its net health benefit is superior to that provided by lifestyle management alone? Jeff, do you want to again briefly point people to the tables in the evidence summary, and then we can see if there are any questions?
Yeah, so benefits are table 5 primarily, the cholesterol findings, table 7, and the harms, table 9. So again, mostly pages 6 and 7 in the evidence summary. So we see significant reduction in fibrosis with no worsening of NASH, but a non-significant difference in NASH resolution without worsening of fibrosis stage. The LDL cholesterol initially went up with obeticholic acid, but did come down over time, mostly due to it, though again, you heard the comments from the company. Our assessment is it's mostly due to the initiation of statins and intensification of therapy. And then harms were clearly more discontinuations due to adverse events. A lot of patients get pruritus, but no difference in mortality.
Okay, and the ICER evidence rating was PI, right?
Yes, PI. So the things that swayed us were a little, so no significant improvement in the second of the co-primary outcomes, the trend in the wrong direction with lipids, and a greater discontinuation due to adverse events and a lot of itching.
Okay. Questions from CEPAC? I did let the discussion run a little bit longer on the first topic because I knew that we would get out some of the underlying issues that would be applicable to both drugs. Any specific questions about obeticholic acid or comments? Okay. Clinical experts, is there anything you'd like to add? You've also heard people now walk through their thinking about the yeses and the nos. Anything you want to add about OCA in that regard? Welcome back, Adnan. Yeah, go ahead.
Yeah, I was in inpatient service, so having trouble getting back.
Imagine taking care of patients. What a waste of no. I'm really appreciate that you're able to fit this in.
I'm glad
so
to be
please,
here.
Please go
I
ahead.
think this is a very valuable discussion and analysis because it's a chronic disease and these are important outcomes we're looking at. They are surrogate markers, but there is a strong growing evidence from retrospective and prospective studies that fibrosis regression is an important endpoint. So it's kind of like in life that you have the early adopters and then the people who want best evidence, and that'll come, but it'll take many, many years. I do think that in terms of there are valid points that we have incomplete data from one trial, just top line results, although the results look a little bit more convincing in terms of benefit and risk balance.
Mm-hmm.
But I hope that the final results will sort of show the same. And the interesting part about obeticholic acid and resmetirom hopefully will show the same is when you look deep down into trials, what's really meaningful is a stage 2 fibrosis improvement. And obeticholic acid had a small but statistically significant improvement over placebo there as well in terms of fibrosis improvement. And we expect that when the final results are there with resmetirom, they will publish those results as well, but I haven't seen them. So that to me suggests there is modest clinical benefits, as we're saying. It's just the balance between the risk and the benefit that seems to be swaying us, for one recommendation for a drug appropriately versus another. So that's my 2 cents for it.
Okay. Danielle, please, if you'd like.
Yeah, I know these drugs some of the data are early. We don't have the clinical endpoints. I'm just concerned that if we're waiting for the perfect trial to show all these clinical events that are going to take 10 years to occur, that perfect is going to be the enemy of good. So I think, again, there's still a lot we have to learn. But I think that, this is a first step in pharmacotherapy to help these patients. And the other thought is that because fatty liver is this huge public health problem, even these small benefits can potentially have huge benefit to society because of the scope of the disease. And, again, just thinking about the individual impact on patients and their families for having end-stage liver disease and needing transplant, even though I run a transplant program, I would love to have to do fewer transplants. So I think these are really things that we do have to take into consideration. And there, I did want to mention, just from comments earlier about quality of life, there are some quality of life data out there, showing that, with these drugs, if there's reduction in liver fat, it can be associated with improvements in markers of quality of life.
Okay, thanks. David?
So for me, again, taking the role of primary care doctor, I understand the hepatologist view of things where they're seeing a ton of progression to cirrhosis, and the people they're seeing who need liver transplants have become this large group of people with NASH. But NASH in most patients is a manifestation of the metabolic syndrome. And most patients with NASH, including those with significant fibrosis, are going to die of cardiovascular events. And a drug that raises the main marker we use when worrying about lipids scares me. And so not having long-term outcome data in this situation makes me nervous. And I don't view this as just being a person who demands waiting for the endpoints. There are reasons to be scared.
Okay. Stuart?
I'm curious what people have to say on the line here about the pruritus incidence, which is over 50% of those patients with OCA. And I think we haven't heard from anyone that's suffered from that. I recall in the distant past having body-wide pruritus due to INH. And so it's no small deal to have this side effect. And I'd like the clinical experts to comment about the impact on those patients who have sustained that as a side effect.
I will say pruritus for patients is a horrible, horrible symptom. Does have an impact on quality of life. I do have concerns that, clinical trial patients may be, more tolerant or more willing to continue on a medication despite side effects. So, there is that chance that if the medication is in the general population, that the discontinuation rates may be even higher. I think we just don't know, but I think it's certainly something that we have to be aware of.
And yes, pruritus is no small joke. It is an impact on quality of life, and of course that's the first thing people notice when they have a chronic disease. But we have real world experience with obeticholic acid and PBC and a management plan for pruritus, and it's an immediate thing. So it depends if the drug is going to go to a bunch of providers who don't have comfort in managing pruritus, and they're just going to start it and forget about it. That's not what you should do with this drug or any new drug. You need to be aware of the management plans for the drug, efficacy as well as side effects. For both these drugs, these trials are relatively small compared to the number of patients that they can be used in. And in phase 4 or real world experience, we find a lot of new things manifest with all new drugs. So there needs to be vigilance for everything. But I agree with pruritus requires a robust management plan and is a concern.
Okay, thank you. Tim, I'm hoping you're going to be the last question.
Okay, then just real quick. Thanks. I really value the input from our content experts. You guys have been really great. But just, it seems like there's a bit of extra angst about this one versus the other, anywhere from terms like, these are small trials. I have hope that it's going to work out. It's going to be long-term, 10 years plus. I share those concerns. I just share them really, and the role of LDL as a surrogate. I share a lot of those concerns. I just share them across the two drugs. Thanks.
Okay, thank you. All right, let's put up the voting slide, please, and we'll take the vote on obeticholic acid. Is the evidence adequate to demonstrate it has a net health benefit beyond that provided by lifestyle management alone? Please vote yes or no. There we go. Okay, 1 yes and 14 no. All right, let's move forward now. The next set of questions are different for those who have not been part of an ICER meeting before. This is again reflecting the elements that in some sense lie outside of the cost effectiveness and the clinical evidence and relate to either ethical or social priorities and sometimes potential benefits that fall beyond the health benefits even for individual patients. So the first two questions, when making judgments of the overall long-term value for money, what's the relative priority that should be given to any effective treatment for NASH with fibrosis? So we're not talking about the treatments today, any effective treatment. What's the relative priority that should be given to those treatments on the basis of the following contextual considerations? The first is the acuity of need for treatment of individual patients based on their short-term risk of death or progression to permanent disability. This again is meant to capture what research has sometimes shown is a common weight that people would like to give to treatments if they can help people avoid death in the near term. Conditions that lead to very rapid progression or death. I think we've heard a lot about the natural course and history here. And so I'm not sure that the CEPAC needs further context setting around this before they take a vote. But in terms of the acuity of need, again, I know Dr. Bradman or Saeed, the pace at which people progress from F2 to F3, F3 to F4 is widely heterogeneous. But on average, what is the time considered in the clinical field for the progression from one stage to the next?
Yeah, so just on average, and just to make a note that most fibrosis progression studies are somewhat problematic because we don't actually know the second that there is fibrosis progression. But, on average, the number that's been cited is in NASH, it takes about 7 years to go from one fibrosis stage to the next, but we don't think it's a linear relationship. And I think Dr. Saeed had alluded to this earlier in the discussion that the more advanced the fibrosis is, we think the more rapid the progression may be. And there's some data from other clinical trials analyzing the placebo arm suggesting that once you reach stage 3, that it may take only 2 years to progress to cirrhosis.
Okay, thanks. Why don't we go ahead and take our vote on this one? Tim, I think your hand is still up from the last one, I hope, right? Okay, why don't we go ahead and take the vote on this question? Someone's ready to go forward. All right, so the ranking here is from very low priority based on this acuity of need to very high priority. And again, we should have 15 votes. Okay, is one person, maybe one person got pulled away. There we go, thanks. All right, let's see the results. Okay, we've got 6 high priority. I can't see very high priority, unfortunately, in my framing of the results.
1.
1, thank you. Okay, 1, and we see 6 for high priority, 4 average, 3 low, and 1 very low. Okay, let's go to the next question. Remember, again, we're talking about the
Steve,
relative.
Steve, do you mind teasing out real quick out? Shut me up if you want to, but why some folks thought it was a low priority? I'm just, that strikes me.
Again, it's tricky because you're being asked a relative priority question based on something that we don't give you an anchor, either pro or, kind of high or low. But basically, this would suggest that 6 people, for instance, thought that there was a high priority based on what you would have to say is a relatively high acuity of need based on the short-term risk of death or progression to permanent disability. So that's the short-term severity, if you will, acuity of need. The next one's going to be the long-term impact of the illness on people's lives. So if we do go to the next voting question, it's the magnitude of the lifetime impact on individual patients of the condition being treated. So now we're no longer thinking about what's happening in the near term, but what's the magnitude, again, compared to, if you will, the average condition that we were making decisions about in terms of the priority in our health system. So actually, Eric, before you ask a question, I just want to invite the patient expert, Kimberly, you, and I'm sure you are aware of others' experiences. Would you like to again frame what you view as the lifetime impact? We did hear some excellent testimony during the public comment as well.
Well, my lifetime has been extended. I would not be here. I was supposed to die 7 years ago. I was diagnosed and they told me at end stage I had a GI bleed. And they told me I had 2 years. And I had a GI doctor who went above and beyond, and he was with me every step of the way, referred me to transplant center. And I was transplanted 2 years and 2 months after I was transplanted 2 months after my expiration date. Since then, I've been able to help be caregiver for my elderly mom and my brother who's on dialysis. I know that I'm going to live a lot longer than I would have. I hope that I'm making an impact for future liver patients. I know that I'm a part of a bunch of groups, and I know that daily there is posts that say in memory of. Last night, a lady lost her husband to NASH, and he was 34 years old, father of 3 young kids. I have part of a local trio support group Zoom. We lost a lady 2 days ago, and she was a Native American. I'm half Hispanic. My dad is Hispanic. So I know that I wouldn't be here right now. So I am very grateful, and that's why I'm here today. And I really appreciate being able to speak. As far as the quality of life, when I was sick, I had, like I said, a life-threatening GI bleed. I was actually trying to be a living donor for my brother who's on dialysis. So if I would have had this medicine when I was first ill, I could have maybe had it reversed to 0, and maybe I could have been his donor. I don't know. That might be wishful thinking, but I do know that I would have been more helpful when taking care of him if I hadn't been sick for this 2 years. I have a big family, and I have people that rely on me. And so this medicine would definitely help others. And also, you know, like they said earlier, Hispanics and diversified populations would be helped. And as a matter of fact, when I was diagnosed, I didn't have any insurance. So I know it's a cost, but it's a greater cost that I had my transplant. I think it would cost a lot less if I was able to get this drug and not ever progress to needing a transplant. So I think this drug is very important, or any drug treatment that will work is very important to liver patients and people that are at risk for being a liver patient.
Thank you. And by the way, thank you for doing yeoman's work today, because we usually have 2 patient experts and 1 had a family emergency. So you're doing great work representing the entire community. We really appreciate it.
Thank you.
Eric, please go ahead if you had a question or comment.
Yeah, Kimberly, thank you for sharing the testimony and giving us all some special context for the condition. I think when I look at this particular question, I'm likely to score it average, not because I think anything less of, you know, Kimberly's comments, but I think about other chronic conditions, and I'm also in many ways trying to figure out what condition it is that I'm treating, right? So the early stages of this particular condition, you know, is the magnitude of the lifetime impact on very, very low staged NASH, is it that impactful, right? Or is this a very effective treatment with a higher risk to basically a higher risk to severe progression like F3, or you know, really reducing the risk of the need for transplant? So I guess I'm just telling you, like, as a group, like, I kind of put it in this category of, like, in the grand scheme of other conditions that we've looked at, I kind of put it in this average priority, but I struggle a little bit with what is the patient profile that I'm treating. Mm-hmm. So I'm making some assumptions in this particular, in the way the question is worded, of like how I'm thinking about that. And I just wanted to share that, you know, with the group.
Thanks. It's very helpful. Any other questions or comments? Okay, let's go back to the voting slide. So this one, again, it's framed from very low to very high priority based on the magnitude of the lifetime impact on individual patients with the condition. There we go. All right. I need a new computer screen because I still can't see very high priority. Somebody else read it out?
3.
3. Thank you. High priority seems to be in vogue. So we have 8 there, 3 average, and 1 low. All right. Now we have 3 additional questions, and these are going to be framed specifically around resmetirom. We could have picked obeticholic acid. We decided just to pick one or the other. We did recognize that we thought that the CEPAC would believe that the evidence was stronger for the overall, if you will, the evidence being adequate to demonstrate its net health benefits. So we're going to frame these around resmetirom. And the question is, what are the relative effects of resmetirom versus lifestyle management alone? Your best judgment of that. What would its effects be on the following outcomes that also inform our judgment of the overall long-term value for money of resmetirom? And the first of those is patients' ability to achieve their major life goals related to education, work, or family life. Again, what we mean by this is we can measure, you know, the effects on quality of life and length of life, but sometimes depending on how that's either grouped together or spread out over a long time period, and when it happens in people's lifespans, it may have special broader effects on their abilities to, again, kind of live their fullest life. And we just heard earlier from Kimberly, I think, some great experience from her and her family around this. Does anybody have any questions that they'd like to ask, or any thoughts on how they're going to vote on this one? Reem?
Thank you, Steve. And no question, but I think part of also what we heard earlier is that it is helpful to many populations who suffer from chronic conditions to have the hope of a treatment. So even sometime while the comorbidities like depression and like fear of what's going to happen and so on, I keep that in mind as I'm thinking about a question like this, for could it help people to potentially achieve their life goals? I consider these not necessarily clearly delineated health outcomes, but other contextual effects that could help.
Okay, thank you. All right, why don't we go ahead and, oh, sorry, Alan, please.
I just had a question. Does it make more sense? And I wrestle with this every time we do this vote. I know we're in the process of changing it, but to think about the benefit, this question purely in the context of that's the population, say, let's say it's accurate in the trial, a 30% response rate at 100 milligrams or whatever it is, the benefit just to that population, or that benefit relative to the lack of benefit across the entire population?
Well, again, I think you should think about its use in the population that it's been tested in so far and will likely drive the FDA label. So in that population, again, given your understanding of whether you think the drug works at all, if it does, how much, and whether that effect over the course of the years when this will be likely to be treated. I know we're still asking about kind of difficult averages in a way. But that's part of what we need to do since we're thinking in general about a broader population and a single price at the end of the day. Okay, let's go ahead and vote on, I'm sorry, Kimberly, go ahead.
Okay, I just want to okay, the question is it better with weight management alone or without weight management alone? So the drug is better than weight management alone. Is that what the question is?
No, that's actually kind of what they voted on already. This is kind of thinking about whether, based on their understanding of whether it is or isn't, and how much better it is or isn't, whether they think it'll have broader effects on patients' lives and their ability to do those kinds of following a specific course of education or that kind of thing.
I'm sorry I got lost there. My audio cut out for a second. So thank you.
Not at all. Tim?
Steve, there's no place for unknown or do not know. And the reason I bring it up here is it was pretty low on whether there is net health benefit. I think primarily related to whether we think these surrogates are health benefits. So we're sort of forced to either declare that we think there's a benefit or that we know what it is, and that's where to be honest, that's where I'm struggling. I don't know, because that's right. Really what drove me in my original comment.
Yeah,
sorry.
I mean, in general, uncertainty is often a driver of how much priority people would give to a treatment in the context of its potential benefits. So if you think there's high uncertainty that will have any significant benefit, that would probably lead you to have a relatively lower priority for something like this. But again, it's also in your judgment about whether the effects have a specific longitudinal effect on patients' ability to kind of pursue their broader life goals. Okay, Tim, if you don't mind going back on mute, let's go ahead and take the vote on this one. Okay, so this is resmetirom and its ability, and again, we're talking about its ability to help patients achieve their major life goals related to education, work, or family life. You think it's most likely anything from a major negative effect to a major positive effect. Okay, that was fast. We've got 9 minor positive and 5 no difference, and probably 1 major positive since that doesn't add up to 15. Okay, good. Let's go to the next question. The next question is very similar in a way. It's asking you to deal with your own judgment of whether it works and how much it works, and whether that has a spillover effect into the lives of caregivers and their quality of life or their ability to achieve their major life goals related to their education, work, or family life. And again, Kimberly, you described you already talked about how it has affected people all across your family. So I think that was very helpful for the CEPAC to hear. Does anybody have any questions or follow-up comments on that? Okay, let's go ahead and vote.
I was going to say, just remember we did hear from Tony's wife, so she gave the caregiver perspective.
That's true. Thank you for reminding everybody, me too. All right, please vote from major negative to major positive for resmetirom. Okay. There we get 9 minor positive and 6 no difference. Okay, we've got one last voting question before we break and then have the policy roundtable. This is always tricky because, again, we're talking about whether you think resmetirom works based on the evidence, on how much benefit it would have, and would that benefit, given the condition and the context, help society reach its goal of reducing health inequities. So let's talk a little bit about, again, Jeff, you can remind, this was in your slides, but just remind folks about the relative prevalence in different racial and ethnic communities at least. And then we can have maybe some brief discussion around whether this treatment would offer some specific benefits towards society's goal of reducing health disparities.
Yeah, the preponderance of the evidence suggests there's a higher prevalence in our Hispanic population, a lower prevalence in non-Hispanic Blacks, and sort of intermediate in non-Hispanic whites. If you do non-Hispanic whites versus everybody else, it's actually higher, about 40% higher in non-Hispanic whites. So sort of a mixed picture, but there are also socioeconomic differences that have been looked at, and actually income it didn't correlate with NASH prevalence. So unclear what to make of that, though. The thinking would be normally that there would be a higher incidence of lower access to high quality food, higher incidence of obesity, diabetes, and the risk factors for NASH, but that didn't really play out, so that was confusing. And then finally, clearly, patients with less means have less access to liver transplants. So I think there is a clear disparity.
Clinical experts, would you like to? Oh, good. Thank you. I was going to ask you anyway. Danielle, go ahead.
Yeah, I just want to comment on kind of the belief and the thought out there that Black patients have a lower risk of fatty liver. I worry that that idea it's really been published because a lot of the cohorts are really, they don't have adequate representation for Black patients. We also know that Black patients may not be able to access specialty care as often, so they may be diagnosed less. And then are we feeding into the problem of this patient population doesn't have the disease, so we're not going to look for it? So I think that's something that we really have to be mindful of as a community.
Thanks. Adnan?
Yeah, I think that's a great point. You know, we're becoming such a mixed bag that data from a few decades ago probably doesn't apply as strongly anymore, the genetic data. And as far as the income thing is interesting, maybe, rich people don't describe all their income, but we found that, yes, income doesn't correlate when we looked at national NAFLD prevalence as well, but education does, which you could say maybe the difference is education, but education could be a surrogate for enough income versus, so I think there are health inequities in terms of access to higher education and the presence of that are correlated with this as well, that play out.
Okay. I'll just point out again that the CEPAC faces the challenge of understanding whether there are disparities and what kinds, and whether a treatment like resmetirom will help address those, make them worse, have no big difference. So it's a kind of a multifactorial question, and that's something we're going to be also addressing as we go forward. I'm not going to be able to handle everybody's comment here, given that we need to wrap up in just a few minutes. So I'm going to go in the order that they were given, but I'll have to wrap up so we have time to take a break. Eric, go ahead.
I'll keep it very short. I think about this particular issue in this condition and obesity as a significant health disparity in the bias and the discrimination that goes against people that are overweight. And there's a correlation, not 100%, between NASH and obesity. So often we talk about health disparities being sort of an income group or a or a racial group. In this particular case, I think about it in a slightly different way because of the nature of the disease. I just want to share that with the group and why I actually think that there is a higher this for me, deserves a higher rating.
And thanks. Kimberly, please.
Culturally, different cultures have different eating food, different styles of food. And also, like he just mentioned, obesity, genetics has a lot to do with that too.
Okay. Heather, thank you for going so quickly. We'll try to see if we can get everybody's comment in the next 60 seconds so we can vote. Heather?
Yeah, I guess what I'm struggling with is the framing of the question. Not that there aren't disparities. I believe that there are significant disparities, but I think what I'm struggling in terms of voting on is that there's a lack of compelling evidence that says this drug is going to reach those patients that need it. I'm having difficulty presuming that this will make a minor or major positive effect, because I don't think we have the answer to that.
Okay, thank you. Tim, go ahead.
Yeah, I had that concern as well, but I wanted to make the additional point that in the current situation, I do a lot of work on insurance, and the population with the highest uninsurance rate, although everything's improving, of course, is Latinos and Hispanics. I just wanted to point that out. So I shared Heather's concern, and I'm wrestling with in my own mind about the current problems of inequities versus what would happen if this drug were put out there with the high prices that we're thinking about.
Okay, thank you. Let's go ahead and put that voting slide up. Everybody's wrestling has to come to an end as you vote here, please, from major negative effect of resmetirom to major positive effect on society's goal of reducing health inequities. All right. Okay, 9 no difference, then 3 minor positive, 1 major positive, as you can see, 1 minor negative and 1 major negative. Okay, looks like a bell curve almost. All right, thank you very much. We are going to take our break. Let's make it a 9-minute break so that we can return right at the hour, please. We'll have our policy roundtable at that time, including, again, our patient expert, clinical experts. We'll be joined by representatives from the payer community and the manufacturer. So we'll see you right at the top of the hour. Thanks, everybody.